Welcome everyone to the breakout session that you are in, which is reducing health disparities in rural Missouri. And we are lucky we have 4 panelists in our session, so you get an extra bang for your dollar here today. And I'm really interested to talk about how all of what we have gathered and learned so far about health disparities translates into helping our folks out in the hinterlands of our great state. So we've assembled an excellent panel. First we're going to have Andrew Hunter. He is a Zoo Tiger graduate, right, in geography, which turns out to be very helpful as we learn from Dr. Troutman in understanding health disparities. So I won't go through all of this. You have this in your packet, but he currently he's here with us today because he has worked with the state health department working with the MICA system, which is basically our state's surveillance system and clearinghouse, which many of you have probably used in working in grants and community assessments. And he's talking to us today about health in rural Missouri, which is a report they put together that encapsulates a lot of the data that we have available to characterize health in our rural areas. Val Bader is a registered nurse, but we still like her anyway. And she has a specialty in maternal child health. Definitely she is a practicing nurse midwife here in central Missouri. She is working on her dissertation, researching factors that influence unintended pregnancy among young adult women, which is certainly a huge tragic issue in our rural areas. So we'll hear from Val. And then Joanne Martin with the Pettis County Health Department, and we go back a long time. Many a tuberculosis outbreak there in Pettis County, and many a lovely trip down 50 to go visit with Joanne. She is also a nurse practitioner, and she has degrees in adult education from MU Kansas City and community health nursing from the University of Alabama in Birmingham. Her research area has been focused on how individuals define health, both for themselves and their children. She is also 25 years of service in the Army National Guard and a member of the Missouri Disaster Medical Response Team. And today she is talking to us from the local health department perspective on health. And then finally we'll have Rachel Luttrell. She is the director of the Missouri Telehealth Network, which is a really new and exciting way to reach our rural areas. That involves a lot of technology that makes my head spin. So we're so fortunate to have folks like Rachel to usher us into this new age and our ability to serve rural areas. And she will be talking to us about the ECHO project, which I'm very excited to hear about. So without further delay, why don't we get started with Andrew.
Okay, thank you, Linnell. As she mentioned, we're going to be presenting on the biennial report on rural health in Missouri. The primary authors were myself and Becca Michaels, who's here today, and as well Melissa Van Dyne from the Office of Primary Care and Rural Health. So Becca and our unit kind of handled the data pieces on this, the major section, so the demographics, the health status, the health behaviors. And then Melissa and the program worked on the healthcare resources and rural health activities. So before we get too much into the details of it, the main report compares urban versus rural rates for a variety of different indicators. And they reveal that geographic location makes a big difference in looking at health factors. It's not to say that the issues aren't important for urban areas, but as we'll see, this report focuses more on the rural aspect, and for the indicators that we looked at, rural Missourians fare a lot worse than their urban counterparts. The first thing we had to determine, though, was define what the rural population, what that consists of. I was talking to Val and Joanne a second ago. There's a lot of different ways that it can be defined. For our purposes, we needed to pick something that was relatively easy to define and something that was accurate. And so we came up with a two-part definition. The first is pretty easy to understand. The overall county population density had to be 150 persons or larger per square mile. And again, we were defining whole counties as either urban or rural. The second, a little bit more confusing perhaps, if the county contained any part of the central city of a metropolitan statistical area, a census term, then it was also considered urban. Using that definition, we came up with 14 urban counties. Most of them are located in St. Louis and Kansas City, as you can see, a few others throughout the state, and then 101 rural counties. In terms of demographics, the state has a total of about 6 million people. Using that rural definition, we came up with 2.23 million, or 37% of the state population. In terms of population growth, we found that the urban and rural populations were growing at about the same rate, just a little over 6%. That compares to 9% in terms of like U.S. growth over that same time period. However, the population growth was not even throughout the whole state. Some areas saw very large growth, as much as 36%. And then, and I don't know how well it shows up on this map, the lightest two shades are the counties or the areas that lost population. There were 36 total counties that lost population between 2002 2012. 35 of those 36 were rural. For the counties that lost over at least 5% or greater, so that's the very lightest shade, there were 12 counties that fell in that category. 10 of those 12 were rural counties north of the Missouri River. And this is kind of following trends that have been going on in the state since the early 1900s as far as northern Missouri losing population. We don't have time to go into a lot of the socioeconomic factors. They're in the biennial report, though. Some of the indicators, though, where rural populations fared worse than urban included poverty, poverty among children, the per capita income, education, so educational attainment. Crime was one where the rural population did a little bit better, though. In terms of health status indicators, life expectancy at birth is a good overall gauge of public health, or of quality of health, not public health. We found that the urban population, the terms of life expectancy, lived slightly longer, 77.5 versus 76.5 using for the rural population. 1 year may not sound like a lot, but it can still be a meaningful difference. Like we saw with population growth, the life expectancy really varied across the state. There's about a 9-year gap between the county with the highest life expectancy and that with the least. Mercer County up in the very far north part of the state had the highest life expectancy at a little over 80. And then Pemiscot had the shortest life expectancy at about 71. There were a cluster, though, of counties down in the southeast corner that had kind of a block of the lowest life expectancy. Pemiscot was a part of that group. The life expectancy for the southeast BRFSS region was 75.2, which was the lowest. And all the counties in that region were rural. Most of the rest of the time I've got here, we're going to talk about the different death and hospitalization rates. Anytime you see an asterisk, that indicates that there was a statistical significance. So here we're looking at death rates for all causes. The rural rate was about 10% higher than the urban rate, 853 to 778. When we looked at it across time, we see that in 2001, the rates were about the same, and then that gap slowly but kind of steadily increased over the 10 years. It's not real dramatic, but again, that accounts for about a 10% difference between the two groups. When we looked at the hospital trends, it's kind of the opposite. Here, the urban rate is slightly higher than the rural rate, about 4%. So more people are dying in rural areas at a higher rate, at least, while more people are being hospitalized in an urban setting. And that is all based on residents. In terms of hospitalization rates then by county, you can see that to generalize, the eastern and western parts of the state had higher hospitalization rates, while the northeast, central, and southwest parts of the state had lower rates. In terms of leading causes of death, I know there's a lot more information than what you can kind of process in the time we've got to look at this slide. Here we're looking, though, at leading causes of death by type. So we'll see that the rank order there on the left is the rural health, and on the right's the urban. The rank order is pretty similar. In other words, heart disease is number 1 for both groups. Cancer is number 2. There's a few differences, but they're pretty similar. The one consistent, though, is the rural rate for each of those specific causes is higher than the urban rate. So, and in fact, they're statistically significantly different in all cases except for diabetes. When we look at the specific types then, say heart disease, we see that the rural rate was about 10% higher. So this is the top graph on this slide, similar to what we saw for the overall or all causes. And then on the bottom portion, we see that the rates are declining for both groups. So that's the good news. In terms of cancer, in the top graph, we added when possible in this report, we added the healthy people target for 2020, so you can kind of see what we're shooting for in the next 10 years. And here we see that the healthy people target is quite a bit lower than where the rural or the urban population are right now for cancer. Cancer hospitalization rates in the bottom part of the graph, the urban rate's slightly higher than the rural. That's kind of consistent with that overall trend. For chronic lower respiratory disease, this was one of the indicators where the rural rate was quite a bit higher, over 50% higher, in fact. And you can see that across time that's been pretty consistent as well. Anecdotally, the rural health program has learned that a big part of the reason why the rural rates are high for COPD is readmissions. In other words, the same person is treated multiple times for the same diagnosis. In our data analysis, these would be counted as multiple cases. Thus, that's at least part of the reason why the rates are so much higher. The fifth leading cause of death in Missouri was unintentional injuries. Here we've got some slides showing you the differences. For unintentional injuries, they make up, and let me read this, a category. The unintentional injury category includes both motor vehicle accidents, falls, drug overdoses, fires, and drownings. You can see, though, that for the rural population, motor vehicle accidents make up 46% of unintentional injury deaths. On the urban side, just 29%. When we look at motor vehicle accidents specifically, this was one of the largest disparities in the whole report. The rural rate was over twice what the urban rate was. You can see that urban rate's really close to the healthy people target, while the rural rate's dramatically higher. And then on the bottom slide, or bottom data table, you can see that there's some specific counties that are even double what the rural rate is. Say like Reynolds County's rate's 60, so that's again more than double what the rural rate is overall. Looking at it geographically, we see that almost all of rural Missouri is in that, especially southern Missouri is in that significantly high for motor vehicle accidents. In terms of hospitalization rates, on the top slide, the rural rate is a little bit higher than the urban rate for hospitalizations. You might remember that overall hospitalizations, the urban rate's higher, so this is a case where it's such a large portion that it's kind of swung the numbers where the rural rates are higher. On the bottom slide, the good news, though, is that the rates have declined over the last 10 years for both population groups. And the good news for the rural rates are that gap's gotten a little bit smaller. In terms of health behaviors and risk factors, I think most of you are aware that smoking rates in Missouri are high. We were able to use our county level study data to break out the rural and urban rates. We see that the Missouri urban rate's slightly higher than the U.S. rate. The Missouri rural population, though, is about 3% higher than the urban. And all three groups are way above that healthy people target. In terms of obesity, pretty much the same general trend. Rural rates about 3%, 3.5% higher than the urban rate. Both groups are a little above the U.S. numbers. Final graphic I'll show you is on health screenings. Here the numbers are a little bit even greater in terms of a disparity. No mammogram, it was about 10% higher in rural areas. Never had a colonoscopy, about 9%. So to summarize, why is rural areas less healthy? We thought there were three primary reasons: the socioeconomic factor, the healthy behaviors that we just saw, and then also the access to health care. So, obviously the rural areas there's not a hospital just around the corner or within a half mile or mile of you in most situations, so it's a little bit tougher for them to get access. In terms of the full report is available on the Department of Health homepage. I know that they've said these slides are going to be available on this website, so you can access the link here or through the DHSS. As Linnell had mentioned, most of the data that we pulled for this report were through the MICA data tool. It's a interactive web query system. I'll give just a very brief plug. We're going to be offering some trainings throughout the summer, throughout the state, offering information about how you can use the tool, better use the tool, some additional information about them. There's information at the front table listing out the different dates and locations for those events. A report like this can't be put together without the help of a large number of people, and so this is just a small portion of the group that helped us put the report together.
As I'm changing presentations here, if there's any quick questions for Andrew, you're welcome to ask them at this time.
Yeah.
Just any indications about how pockets of immigrant populations may be affecting rural health?
I'm sorry, I didn't catch that.
Pockets of immigrant populations like we have in McDonald County, Sullivan, Saline, or many other counties in Missouri, we do have some really dramatic changes in immigrant population.
Yeah.
And are you examining those groups for this purpose?
We didn't look at it too much for this rural health report, but we did. I know in your book there's a publication we put together on Hispanics and African Americans that we had worked with the Missouri Foundation for Health on, and we addressed some of those issues in that report.
Yeah, I think that was specifically about rural.
But I do see that argument. We just kind of have to. There's a limit to how much material you can cover and. Yes.
I'll just mention, too, that I'm working on the next Disparities report that's going to be released from MSH. We're going to talk about the increase of older adults in rural populations. Because we're creating a map kind of similar to the ones you have with the colors on it showing how much rural Missouri is aging over the next 20 years. So that will definitely be a factor.
Yep.
One more quick question.
I was just wondering, when we access the full report, will we be able to drill down and see like how alcohol may have figured into the motor vehicle deaths and hospitalizations or not?
No, I don't think we don't generally get information on our death or hospital files that we're on what the reason for the report or the accident was.
Hello, everyone. I'm going to talk about unintended pregnancy and how unintended pregnancy interacts with rural health. Unintended pregnancy, I'm going to argue, is a baseline problem that drives a lot of other health problems that we see in rural areas. And I'm pleased to report that I'm using the same map of rural Missouri that Andrew used. I was a little bit worried about this, but I like to find out that I'm on the same page as others. And so basically, any county of Missouri here that has the hash marks, that's an urban county. All the other counties are rural counties. The stars that you see on those certain counties are counties that I contacted prior to this presentation to ask about what's going on in your county in terms of access to contraception. And so I contacted those public health agency directors and asked about that for those counties, and got out of 30 emails, I got 10 responses, so I was pretty happy with that. So I'm going to include that information in this presentation as well. About slightly more than 2 million people in Missouri are in rural areas. The rural poverty rate is higher than urban areas, as Andrew mentioned. Unemployment is higher. Rural residents are less likely to have health insurance. There aren't as many doctors, nurses, pharmacists out in rural areas. And the death rate overall at all age groups is higher in rural Missouri, but as we'll see, infant mortality is also higher in rural areas. And I believe this is what lowers the overall life expectancy. So now I'm going to switch from rural areas to talking about unintended pregnancy. Basically, an unintended pregnancy occurs when somebody gets pregnant. That's almost always a woman, and she doesn't want to be. There's two types. There's the mistimed pregnancy, and there's the unwanted pregnancy. Mistimed pregnancies, if that's greater than 2 years, those have very bad health outcomes. Less than 2 years, it's usually equivalent to an intended pregnancy. Mistimed pregnancies occur in young women, women in their 20s and teenagers. Unwanted pregnancies, by comparison, occur in women at the end of childbearing. This is primarily women over the age of 35. Okay? So do I have any fellow Downton Abbey fans in the room? Remember when Lady Cora announced to Lord Grantham that she was pregnant at the end of her childbearing years? When you provide access to contraception and legal access to abortion, in all places in the world where that occurs, you see a reduction in the maternal mortality rate, and it's because these women at the end of childbearing no longer continue pregnancies when they're unhealthy. Lady Edith represents the more common variety of unintended pregnancy. That is, it's a young woman in her 20s who's not married and she becomes pregnant. These have less health consequences than women at the end of childbearing. Who has unintended pregnancies? Most people want 2 children. Most couples want 2 children. And that translates into women needing contraception for 30 years of their life. That's a pretty long time period. It turns out that the more socially disadvantaged you are, the more likely you are to have an unintended pregnancy. And we see the highest rates of unintended pregnancy occurring in women in their early 20s. It's really, teenage pregnancies are all unintended, but the numbers of pregnancies among teenagers aren't as high as those of women in their 20s. We also see higher rates of unintended pregnancy among Black women, Hispanic women, women with no high school diploma. Women living in poverty are 6 times more likely to have an unintended pregnancy. And unmarried women have unintended pregnancies around 90%, depending on which study you read. In Missouri, for the last year that we have data, 52% of all pregnancies were unintended. So in order to get a handle on what the rate of unintended pregnancy is in rural Missouri, I'm going to use a proxy measure of out-of-wedlock childbirth because so many pregnancies to unmarried women are unintended. If you look at this map, the yellow counties are counties where the unintended pregnancy rate is higher than the state average, and that difference is statistically significant. The state average out-of-wedlock pregnancy rate is around 40%, and that's consistent with the U.S. National rate of out-of-wedlock pregnancy of around 40 of every 100 children are born out of wedlock. But what we see is that in many rural counties, that rate is much higher. Just to the north of Boone County, Audrain County has an out-of-wedlock childbirth rate of 52%. Randolph County is due north, and that's 48%. Saline County, 45%, and Washington County, which is that cluster of 3 yellow counties right below the Missouri River, Washington County is the middle county. The highest rate of rural out-of-wedlock pregnancy is Pemiscot County. As I began to look at bad outcomes, if I found the highest ranking county, I always looked to that boot heel. And many times that's where it was, but we also see now that it's spread throughout the state of Missouri. So I think by proxy measure of out-of-wedlock childbirth, we have a high rate of unintended pregnancy in rural Missouri. By and large, the women who have unintended pregnancy are women who don't use contraception. If you took 100 women who had an unintended pregnancy, 5 of those women would have been using birth control. 52 of those women would have been not using any form of contraception, and 43 of those women would have been using contraception incorrectly or inconsistently. So by and large, unintended pregnancy is a problem of not using contraception. Why is that? Why do women not use contraception? A surprising number of people believe that they can't get pregnant. The actual infertility rate is around 8%, but if you survey young adults, about 16% think that they're infertile, when in fact they are not. Many women fear the side effects of birth control and believe that birth control is unhealthy, despite 50 years of research and common use in the United States showing otherwise. Many people believe birth control is dangerous. People have had other problems with contraception and they don't know how to fix them. Many people report they weren't planning on having sex. A substantial number of women report that they don't have the money to pay for contraception. Many women also have their birth control efforts sabotaged by male partners, and this is a component of intimate partner violence, is often reproductive control. And we find that women who don't use contraception also don't use other forms of health promotion. They're not likely to exercise. They're far more likely to smoke. They tend to have more problems with obesity, and they don't get screened for problems like cervical cancer and sexually transmitted infections. The consequences of an unintended pregnancy aren't very good either. Unintended pregnancy results in abortion, and despite where you are on that issue, most people agree that abortion represents a failure. It's something we would rather avoid. Half of all unintended pregnancies end in abortion. Of the half of those unintended pregnancies that continue, 2/3 are paid for by Medicaid. By comparison, among intended pregnancies, fewer than half of those are paid for by Medicaid. We also see poorer health consequences, of course, from unintended pregnancy, but I'm going to stay on the cost. So I want to just share with you this map of the number of infants born in rural counties in Missouri that are actually on Medicaid. And in the cities, we see the yellow is the highest quintile. In those yellow counties, between 70 and 87% of all infants in that county are on Medicaid. The next color is a light purple that I'm sorry doesn't show up very well on this projector. But in those counties, between 60 and 70% of all infants in that county are on Medicaid. And these are rural counties. And then, as I mentioned, we see poorer health outcomes. Women who have an unintended pregnancy continue smoking during the pregnancy, do not use folic acid supplementation, which, as you know, prevents birth defects. They're less likely to get prenatal care. They have much higher rates of postpartum depression. They're more likely to be victims of intimate partner violence. And once the child is born, they're far less likely to breastfeed that child, which promotes the child's health for the rest of their life. I was astounded when I found this map showing the rates of smoking during pregnancy. This is from 2010. Our state average of women who smoke during pregnancy is 18.4%. If you look, the dark green, those counties are significantly higher than that state average. The very lightest color is significantly lower than the state average. And the middle green, either there's not enough data from that county, and that's true for many of our rural counties, or the county average does not differ significantly from the state average. Okay. Oh, Wayne County wins the Booby Prize here. They have a rate of 42% of women smoking during pregnancy. Just to the north of us, Randolph County is 32%, Northeast Audrain County, 33%. St. Louis County is 9.8%, which is excellent. That's very good. So we know how to reduce smoking rates right here in Missouri. We just haven't translated this out into the rural areas. But many of these rural counties have very high rates of smoking during pregnancy.
Could you tell us, what's the source of all this data?
Sure. This is from the Missouri Department of Health and Senior Services, and it's the county level data that Andrew was referencing as well. Mm-hmm. It's great. It's a great website. Okay. From the child's perspective, the consequences of an unintended pregnancy turn up as increased neonatal mortality. When you look at infant mortality, death in the first year of life, 2/3 of infant mortality occurs in the first month of life. And that's called neonatal mortality, 2.5 times higher from an unintended pregnancy. Low birth weight, up to 1/3 higher. Small for gestational age, also up to 1/3 higher. But the risks don't end after infancy. Those kids go on to have a higher rate of being in protective custody as they get older. And here's our map of low birth weight. In many counties of Missouri, this is actually from the March of Dimes, and in many counties of Missouri, there's simply not enough data to show a significant difference. But the counties where there is enough people, you can see that the rates of low birth weight are significantly higher. The rates of preterm birth are significantly higher, and the rates of infant mortality are significantly higher. Overall, the United States has an infant mortality rate of slightly more than 6 per 1,000 kids. Missouri is higher than the national average, 7.5 per 1,000 kids. And these counties in Missouri in dark green, the rate of infant mortality in some cases approaches 1%. I have a slide also showing that your risk of being abused or neglected as a child is also much higher in the rural counties. Abstinence, we have 2 options for preventing unintended pregnancy. And the first one is abstinence. And according to our state law, we have to emphasize abstinence as a way to prevent pregnancy in school. And that works really well for people who have a low libido. Willoughby evaluated the amount of sexual activity people engage in among young adults, and he found 3 broad categories. There's about 1 out of 3 people who really aren't that interested in having sex. They might occasionally think that that's better than what's on TV, but they really don't have a high need for contraception. The largest group of people is this average frequency sex engagers, and these are people who have 2, maybe 3 partners through their lifetime, and they engage in sex once, twice a week, and they can be protected from unintended pregnancy by things like condoms and birth control pills, but probably not things like diaphragms. Diaphragms are probably good for people who are infertile. And then we have this group of high-frequency sexual engagers, and these are the people that really need the highly protective forms of contraception. These are people who engage in sex on a daily basis, have more than 6 partners by the time they're 20 years old, and they are at highest risk, of course, for unintended pregnancy, and they're going to need forms of contraception that are more effective than condoms and spermicide or birth control pills. They're probably going to need IUDs, Implanon, Depo-Provera shots. Those things are in short supply in rural areas, and they're also providers who know how to insert and manage those devices are in short supply in rural areas. One of the other issues with looking at how the rural lifestyle impacts unintended pregnancy is that we don't know a whole lot about it. Researchers basically have access to people who are engaged with large institutions like colleges, universities, the military, and you don't find large institutions in rural areas, or they wouldn't be rural areas, right? Social norms in rural areas probably also impact the risk for unintended pregnancy and are probably different. Ironically, where there are less people in a rural area, you may actually have less privacy. If I go into the drugstore, I'm going to know the clerk, I might know the pharmacist, I might see other people in the drugstore who are going to watch me buying condoms. I don't even like to buy tampons, you know. So the social consequences of buying birth control are going to be higher. But we know that there's an unmet need for contraception in rural areas. The Guttmacher Institute estimates about 300,000 rural Missouri women do not have access to contraception. These are the counties that I contacted. And in nearly every single one of those respondents, the public health official said that what was needed to make contraception more available in rural areas was lower cost contraception. Rural areas also, you have to drive farther to get your contraception. And so not only do you have the cost of the contraception, but you have the cost of the transportation. And in some cases, especially up here in this northwestern corner, people were driving 60 miles to get a pack of pills. Finally, most of these rural areas get their contraception from the Title X family planning program, which was started in 1970 to provide contraceptives to women who were poor. That funding is probably going to be diminished dramatically because of the Affordable Care Act and redirected to training providers. And so the federally qualified health centers in these rural areas, health departments, and other agencies that have been providing contraception will no longer have access to that because that funding is going away. What are some of the solutions to meeting the need for contraception in rural areas? I'd like to remind you that prior to World War I, condoms were available only as a prescription. And the attitude at that time was that if a man decides to have sex, then he should live with the consequences. And if that means sexually transmitted infections or pregnancy, then that's his problem. We're not going to make condoms available. Secretary of Navy Franklin Delano Roosevelt put condoms in the supplies of all the sailors at that time during World War I because he knew these young men would have sex as soon as they could. After that, condoms became available over the counter in the United States. Currently, Walmart pharmacies carry Plan B, and it's not behind the counter, it's out on the shelf. There are Walmarts in many communities, and there's also a generic equivalent. It's extremely expensive, $35 for probably 12 cents worth of drug, and so the markup on it is huge, but it is available. I don't know if providers in rural communities know this. I don't know if the public knows this. I already mentioned decreasing the cost of birth control, and we can do that easily with Medicaid expansion. Missouri Foundation for Health estimates that if Medicaid expanded in Missouri, mostly women with children would go on Medicaid at this time. There are 98 clinics in Missouri that receive Title X funding. That Title X funding is going away, and that money served 60,000 women in Missouri in 2013. Finally, ACOG, the American Congress of Obstetricians and Gynecologists, argues that oral contraceptive pills should be available over the counter. That is, all forms of birth control pills. These medications are far safer than many of the other medications we have available over the counter, and this would go a long way to decreasing the cost and increasing the availability of contraception. So in closing, I'm just going to say that I'm arguing that unintended pregnancy is a significant contributor to poor maternal and infant health in rural Missouri. There's an unmet need for contraception in rural areas, and that's complicated by geographic distance, social norms, and poverty. Title X funding is probably going to go away, and most Medicaid expansion is going to cover women with children here in Missouri. I think that the unintended pregnancy problem is likely to worsen in Missouri if we don't take steps to correct it. Thank you.
A couple quick questions for Val. Yes?
So I know that prescription assistance programs are available through many pharmaceutical companies for poor individuals, and a lot of those, like minus insulin, can be mailed to them. Is that possible with contraceptives?
Yes. Contraceptives can be mailed to people.
Okay. Do you see that happening in a lot of rural areas?
I don't know the answer to that. I'm sorry.
I had a question, Val. So on that laundry list of the reasons why people don't use contraception, with all of this in the news about policies and religious beliefs and contraceptions, I was surprised to see that like religious philosophies wasn't one reason that in your list.
Well, so I worked on a reanalysis of data with Pat Kelly from University of Missouri, Kansas City, and we actually looked at moral judgment as a component on whether or not people use birth control. And it does turn up to be a factor, but it's like it accounts for like less than 8% of the variance in why people do that and why people will not use birth control. That is true for some people, but it's very limited.
Interesting.
I know.
Because it's taken on a big monstrous presence in the news and in the debate.
So many of you who have also worked clinically realize that there's a big gap between what people will say publicly and what they're going to do privately. And it took me a long time to and I kept having to relearn that in clinical practice. And I think that's what's at play here.
Okay. All right. Well, Andrew and Val have set the stage for all of our challenges in rural health, and Joanne's going to tell us what we're going to do about it, right? So.
Okay, well, I will try. We've been talking kind of on a global scale, and now we're going to talk about some very specifics in one rural county. And I hope you noticed from all the maps that were placed up there where Pettis County is. We were kind of in the middle of everything, which sort of surprised me because it doesn't feel like that from my perspective. And I think sometimes it's really hard to see the forest when you're in the middle of the trees, that you're even getting any place. So, okay, this is a little bit about Pettis County. We are a what did I say we are? Micropolitan. We're a micropolitan. That's a new word to me. But anyway, this is a little bit about Pettis County. We have Sedalia, and then there's the rest of the county. In the whole rest of the county, there's not a grocery store, there's not a restaurant, there's not anything except a couple of gas stations, convenience stores. So if you want to do anything in Pettis County, you pretty much need to come into Sedalia. So what happens in Sedalia strongly influences the rest of the county. Okay, as you can see, this is what we look like. We're younger, we're older, it's interesting because our Hispanic population has grown significantly in the past about 20 years now. Our foreign-born population has also grown because we've had a large influx of Ukrainians that have come into our community. And as you can see, we have a significantly larger population that does not have English as the first language in the home. And we're poor. So, you know, we've got some challenges in our community. And I think, you've probably seen this list from everybody of what are the major health problems in our community. Well, we do our community assessments faithfully, and you can go back for lots of community assessments, and the list really doesn't change a whole lot. We've been working on these challenges. So, I'd like to talk a little bit about the uninsured population. We have some challenges with access to care. During the recent enrollment for the ACA, our federally qualified health center was the primary source that did the enrollment for our county. And they found that 43% of the people that tried to apply for health insurance didn't get it because they were not poor enough, but too poor. They fell below that 100% of poverty. So our uninsured population is not going to go away very well in our community. Plus, we have a significant portion of our community that is not eligible for health insurance for other reasons. For immigration reasons, for they're here legally, but they haven't been here 5 years, a lot of different reasons. And according to the community health ranking, we have about 20% of our population that's uninsured. We rank 90th in clinical care, which is not anything to be very proud of. And one of our challenges is our uninsured population rate. We have a primary care ratio of one primary care provider to 2,481 people. And according to HRSA, we're bad, but we're not bad enough. So they took away our health provider shortage area designation on the last go-round because they said, well, you're not as bad as, guess what, the Boot Hill. You're not Pemiscot County. Poor Pemiscot County. I mean, everybody's always beating up on Pemiscot County. But we actually know that this is a problem for our community because the CEO of the hospital rings my phone regularly going, when are we going to get that back? Because they're trying to recruit more primary care providers into our community because we anticipate in the next 5 years we will have 5 primary care providers. Out of our basic family care providers, we only have 10. So we're looking at the potential that half of them are going to retire, but we're not bad enough yet. So this is an ongoing challenge we have. So our community took a look at all this and said, okay, we've got some access issues, we've got some challenges, so what are we going to do? We're just going to try and help people to be healthier so that perhaps they can not have to be as involved with a primary care system that isn't really providing a whole lot of access. So we developed something called the Blue Ribbon Health and Wellness Steering Committee that came out of the Blue Ribbon Health and Wellness, the big overall Blue Ribbon Health and Wellness Steering Committee, and then we had the Blue Ribbon Steering Committee, I'll get this right, and then we had the Blue Ribbon Health and Wellness Steering Committee, too many steering committees in this story. But anyway, we came together and said, we've got to do something. For those of you who may not be aware, there are 25 counties in the state of Missouri that are in Nobody's Foundation area. We don't fall under MF, Missouri Foundation for Health. We don't fall under Kansas City Foundation for Health, and we're one of those counties. So we don't have any foundations that we can apply to help us. So we had to figure out how to do this basically with our own resources. So we did that. And in 2012, we had an opportunity to partner with the University of Missouri and develop the Healthy Communities Initiative. And it came about kind of serendipitously because it was one of those deals where I happened to hear Nick Butler talk about health literacy at a conference, and I went back and told everybody, hey, there's this great program on health literacy. We really need that. And somehow we ended up here with this initiative. But anyway, so it was a great partnership. So as you can see from this slide, we have a lot of different people who serve on our Health and Wellness Steering Committee, lots of representation. And in that, we have the subcommittees that are listed there. And I'm going to tell you a little bit about what we've been able to accomplish under each of those. So I'm talking about successes. Nick, I just talked about you. We've talked a lot about our problems today, so my talk is a little bit on some successes that we've had. Okay, so our University of Missouri project team partners represent a lot of different disciplines within the university. And it's turning out to be a very great relationship for both groups to experiment and try and figure out a little bit about how we're going to tackle some of these problems. So, how we've worked together. Our Healthy Communities Initiative has developed a framework for addressing a variety of issues that face our community. Our university partners have provided research support and all these other great things up there. And for those of you who are in academia, you love to research. You can do data searches. You can do all these wonderful things. Those of us who are on the front lines want to do something. Don't talk about it. Let's just do something. So our university partners have helped us with the research part and have helped us look at where we're going, to plan the evaluation part, and to be able to come up with something that can be reproduced in other parts of the state, which is part of what the university was looking for, was a community where they could also try out some ideas and see how they worked so they could be implemented throughout the state. And one of the things we're working on is a health impact assessment. And that was brought up this morning as a way to look at how an event has an impact on health within a community. So I'm going to talk about successes. It's good to talk about successes. One of our subcommittees called Clean Air Sedalia, and a miracle happened. If you've ever been to Sedalia and Pettis County, to say we are conservative is probably a liberal description of us. We have a bad habit of saying it's always been that way and it's just good enough. But anyway, I'm a rebel. I am not a native Sedalian. I moved there. So anyway, I'm viewed as different. But anyway, we did actually get an indoor smoking ordinance passed by the city council with the political courage of our mayor, who broke a tie, I don't know how many times. It was finally upheld in 2013, 3 times, yeah, 3 times. And we, in public, we recently had an election where there was a very clear difference between those who supported the smoking ordinance and those who did not. And I am pleased to say that everybody who supported the smoking ordinance won in great majorities. So we've finally put this one to bed. And according to the most recent county health rankings, our adult smoking rate dropped from 29 to 25%. Yay! So a success. One of the nurses on the staff of the health department has been spearheading this, and she is about worn out. And somebody said, well, let's go tackle the county. So on Monday, we're going to go talk to the county commission. I can tell you where the answer is, but we're going to try anyway. Sometimes you just have to smile at people and nod your head a lot. Okay, our breastfeeding coalition. We all know breastfeeding gets kids off to a great start. And so with the help of our university partners, a research study was done. And what it identified was there's a big disconnect in our community between what information is being provided to new moms. And so now we're working on trying to get everybody on the same sheet of music to provide consistent information, and they're exploring a concept called the Baby Cafe. And the Baby Cafe is an international organization, I guess, that sets up breastfeeding areas where moms can drop in and be able to receive help from lactation consultants. And if we pull it off, we'll be the first one in Missouri. So our hospital partner hasn't said no yet, so we're smiling, nodding, and helping them along. Okay, our Healthy Living Action Group. We started a program called Healthy You. It took about 1.5 years of very intensive work to get going. It runs on the absolute proverbial shoestring. And Healthy You has actually convinced nutritionists, fitness trainers, and other folks in our community to volunteer their time to help our 12 selected candidates. If anybody's ever seen The Biggest Loser, that was kind of an impetus to get this started. We're now in our 3rd year of this project. We actually got a grant. our first grant. And so they're actually able to give our trainers and coaches a little bit of a stipend for their help. But it has gone from focused on these 12 people to a pretty good-sized community event. We have a community weight loss support group that averages around 20 people now. We have outdoor activities. This weekend is the Lub Dub, which is the culmination of the Couch to 5K program, which has been a 6-week, I think, training program to get people off the couch and able to participate in a 5K. So we got people all over town, including my own staff, who are about to drive me crazy because I can't work in my office without one of them coming by going, come on, it's time for a walk. Let's go for a walk. Let's go for a walk. Time to walk. I'm like, okay. I've been working on a big grant, so I haven't exactly been the best participant. But anyway, so we're getting going. And our university partners have done some analysis of our first year's data. Our Adolescent Health Coalition, there is hope in rural Missouri to provide medically accurate sexual health information in schools. Believe it or not, we actually pulled it off. And so we have gone into 2 of our school districts and provided the whole program. And we have gone into other schools to provide parts of it, including our local Catholic high school, which was amazing to me, but we did it. And so we have partnered with our university partners on learning about getting to objectives, and we're working with our university partners to develop a photo voice project for at-risk teens. And we also, I forgot to put in here, have a teen outreach program grant, so we've been doing the top program at our alternative high school. And we've had really good success with that, and we're very excited about it. Okay, some of our other successes is we receive funding to improve primary care practice and increase implementation of patient-centered medical home through our university partnership. Sometimes you have really great ideas, and they don't turn out as well as you planned. And this was a learning experience that I had to accept. Didn't work exactly as I thought it was going to work. But we planted the seeds, and this one's going to take a little while longer to grow. But it's not totally wilted, it's just resting. We've trained a number of community members in how to conduct health impact assessments, and there's going to be training available on conducting health impact assessments that's coming up on the 11th of June that I believe is in partnership with Missouri Public Health Association and the university. And I think there's a flyer in your packet. Dr. Edison said something about that. So, but it's really great training. We're working with our partners on developing a workplace wellness coalition with business and industry professionals. We're participating in the CAPE project that is being funded through a grant at the university. And we're working on bringing health literacy education to providers and community members, which is how this whole project started. So, and finally, one of our biggest successes is we actually got the city of Sedalia to add a section on community health and the improvement of the health of the citizens to the strategic plan, which for us is truly a first. I'm still working on those, social determinants of health, but at least they put health in the strategic plan, so that is a big step forward. Okay, so in conclusion, improving the health of community requires a lot of different partners. We in rural communities, as it's been pointed out, have a lot of problems with health disparities. We frequently do not have a lot of resources. We don't have a lot of financial resources. We have to figure out how to do it within our own community. And the most important thing about moving along is getting the right people at the table. And you saw all those people who are involved in our Blue Ribbon Health and Wellness Planning team. And it's taken a while, but everybody on that team is truly committed and truly looks at what resources they can contribute to this effort. And our university partnership has brought us additional resources for which we are truly grateful. But we were able to start this before our university partners joined us, which I think made us appealing to the university to come and work with us. And sometimes it's an open mind to say, sure, come on down. We'll be your guinea pigs. You can try out your new idea with us. My staff hates when I go to a conference because I always come home with some scathingly brilliant idea. And for those of you who are old enough to remember a movie called Trouble with Angels, Haley Mills always had scathingly brilliant ideas. So my staff truly hates when I come home from a conference and go, hey, I've got a scathingly brilliant idea. And they all roll their eyes and they all go along with it because I'm the boss. So anyway, just remember, you don't have to reinvent the wheel. People are there to help you. Call us. We'll be happy to share whatever we've done. And you can do it on a shoestring. So there's lots of resources, and thank you.
Thank you, Joanne. I, for one, hope you keep coming up with those brilliant ideas because that always means you need students, and I have lots of them. Yeah. So, any quick question for Joanne, who is just awesome.
Is it University of Missouri that's your university partner? Yes.
Okay. So, two quick comments while I'm figuring this all out here. One is, indeed, we do have the health impact assessment flyers in your folders, so if you have not lost your folder yet, like I've already lost my folder today, get out your folders and make sure you mark your calendars for that training. And also in your folder is the little yellow papers that where you can write your ideas down that will be discussed with our choir director, Dr. Edison, at the next session. So I hope you are thinking of ideas, scathingly brilliant ideas to put on your papers so we can generate discussion. And if anyone happens to find a folder with a clearly brilliant idea in it, that's probably mine, so I want it back. So I hope it turns up, so because I can't remember what that idea was anymore. So, okay. All right, so next we have Rachel to describe the ECHO project, and I'm really excited to hear about this. So.
Great, thanks. Thank you. Congratulations, Joanne, on all your good work and successes. I'm going to talk about a project that hasn't even started yet, so we hope we'll be able to copy you in a couple years. Yeah. Okay, so who has heard of telehealth before with a raise of hands? Wow, almost everybody. So I've been looking for this picture from the Jetsons for several years now. I finally found it yesterday. I couldn't believe it. So telehealth obviously was invented in the 1970s with George Jetson, and or 60s, is that right? I saw it in the 70s, sorry. So telehealth is the use of technology to bridge distances between patients and provider, and in many cases it involves live interactive video like we see on these two pictures. So on the picture, the real picture in the left hand, Will is seeing a pediatric dermatologist over video conferencing. So for subspecialties and subspecialty care, live interactive video conferencing works very well in many different types of specialty care. So the number one use of telemedicine in the U.S. and around the world is telepsychiatry. That's a profession that the doctor normally doesn't have to put hands on the patient, and so video conferencing works very well. Some studies show that patients actually prefer telemedicine to in-person visits in telepsychiatry. So, so we've been doing telemedicine here at the University of Missouri for 20 years now, and it's really hard to get providers to use telemedicine for a variety of reasons. They don't want to change the way that they do practice. For a long time, they didn't get reimbursed for it. That's, as you can imagine that's a big barrier. Cost of equipment is high, there are broadband issues, all kinds of things. So gradually over the year, we've broken down barriers, but we still focused on the model of one provider and one patient. And so regardless of how many barriers you break down, you're still very limited if you think about the 1-to-1 ratio. So recently, we found out about a new model of telehealth, and it's called Project Echo, and it came to us from University of New Mexico, Dr. Sanjeev Arora, who is a hepatologist. And the ECHO model, ECHO stands for Extension for Community Healthcare Outcomes, and it's based on the agriculture extension model where you create local centers of excellence. And so I'm gonna sort of go through this piecemeal, and hopefully you guys, it'll click in your mind, because the last 4 months I've been explaining Project ECHO to a group of people in Jefferson City, and it's taken on average 3 times for me to explain it before they get it, but I think you guys are much quicker and you're going to be able to get it much faster. So the basic tenets of the ECHO model are that it's technology enhanced education and training for primary care providers. So right off the bat, you see the big difference between this and the telemedicine model that I showed you on the previous slide. This is education and training to primary care providers, and they're primary care providers that want to be educated and trained. It's a disease management model to reduce variations in care and share best practices. So I know earlier today we heard lots about the different ways that different doctors practice and reducing in wide variations in cost. And in this case, I'm talking about wide variations in the way patients are treated and the care model. So we're looking at best practices and evidence-based medicine. We're going to use case-based learning and learning by doing and co-management with an interdisciplinary team of specialists. And we're going to monitor the outcomes. So Dr. Arora is a hepatologist, as I mentioned before, and he was in New Mexico at the University of New Mexico treating hepatitis C. He had a 10-month wait to see new patients. And he came to the realization that there's no way he's ever going to get rid of that wait. So he came up with an idea of Project ECHO, and he went around the state and took volunteers, and he said to the primary care doctors, who wants to be an expert in hepatitis C and be able to treat your own patients in hepatitis C? And he got about 20 primary care providers, both physicians and nurse practitioners, that wanted to do that. So he, on his side at the university, got together a group of specialists. Now, what he says, so he started hepatitis C ECHO first, but then he thought, I can do this for all different kinds of different disease states. So he always says if it's complex, costly, common, and chronic, you can probably do an ECHO around it. So this is a list of ones that we want to get started in Missouri. And we've talked to the Missouri Department of Social Services, the Missouri Primary Care Association, and we're going to be doing some surveys to see if we need to adjust this list. But some of these different, as you can see, chronic pain management, that was the number 1 on the list of the Missouri Primary Care Association. Mental health and substance abuse was number 1 from Department of Social Services, as well as high-risk OB, which is a high-cost specialty service. So these are some of the different areas you can provide ECHO clinics in. So an ECHO clinic itself looks like the interdisciplinary team with the medical specialist, a behavioral health specialist, because many of the drugs that are prescribed cause depression or other mental health problems, a pharmacist, and a social worker. Those could be adjusted by the disease. So in a diabetes ECHO, you might have a person that's an expert in nutrition rather than one of these other experts. And every week over video conferencing, they connect to 15 or 20 different primary care providers. And during that ECHO clinic, they do case conference. So those primary care providers present case after case after case, and everyone on that interdisciplinary team can give their opinion about what to do about that case. So the primary care doctors are learning from the team, they're learning from each other, and that interdisciplinary team, they're learning from all those primary care providers. So Dr. Aurora did a study on his hepatitis C echo project after a couple years, and he found that after about 2 years of training, ongoing training and support for these primary care doctors, the cure rates of hepatitis C from those primary care doctors, mainly in rural areas, was exactly the same as the specialists at the academic medical center, which is no surprise, right? These people wanted to learn, they're capable of learning, those primary care doctors. I think that one of the things that he says is that adherence to medication and treatment is much better from the primary care doctor because they're much closer. They understand the social determinants of health of the patient. And so oftentimes they keep the patients going through the treatment. So some of the benefits to the rural providers is that every week during those echo clinics, they get no-cost CMEs, continuing medical education credits, which they are required to get. They get professional interaction with colleagues with similar interests. And I know Joanne mentioned that their number of primary care doctors is shrinking. We think one of the ways that we can enhance professional satisfaction in rural areas are projects like ECHO, where primary care providers can have ongoing support from the medical center that oftentimes they might have graduated from here, so they have a lot of contacts here, and then also having a network of colleagues around the state. One of the tenets of professional satisfaction also is to mix work and learning. So providers in rural areas, all they do is take care of patients. They never get to get additional training and learning, and this ECHO project would provide them with that source of ongoing learning. They get access to coordinated specialty consultation, which is the medical home model. This formalizes it in a way that partners them with the best treatment scenarios. And they also get to keep and treat their own patients instead of continually referring them to the urban centers. Some of the benefits to health system from ECHO is that we are creating centers of excellence around the state, and each of those centers would become a regional referral area for that specific disease or condition. Obviously, this increases access because each of those centers of excellence would provide a place for patients to get treated. It demonopolizes the knowledge so that that specific knowledge that those specialty care providers have doesn't just stay with those specialty care providers. You're not teaching a primary care doctor to be a hepatologist, but you are training them to be an expert in hepatitis C treatment. It's much more cost-effective to the health system if you reduce travel and you keep patients on whatever medication they're on through the course of treatment instead of stopping and starting. And it also prevents the cost of untreated disease. So in the case of hepatitis C, we would be reducing liver cancer and cirrhosis. So the project that we have yet to start here in Missouri, I'll just tell you where we are right now. Our team is Dr. Karen Edison, Representative Diane Franklin, Dr. Wayne Cooper, who is a retired state representative, primary care doctor, hospitalist, and all-around good guy. We traveled to the University of New Mexico, and then we had Dr. Aurora come here for a couple days and talk to people from around the state here. We've been working with the legislators, and we got $1.5 million introduced into House Bill 3, which is the higher education appropriation bill, to start Show Me ECHO. And we have a bill to talk about that the University of Missouri will start the project that doesn't have any funding attached to it, 2125. And you don't need to read that, but if you're interested, you can look it up. So that's all I have on Project ECHO. Anybody have any questions? Yeah.
Right. Who's funding the cost of primary care providers? Is this
the 1.5 million you received, is that paid?
So thank you for asking that, because I didn't have it expressly written in the presentation. So the money to fund Project ECHO goes to fund the percentage of time of the specialist team. The primary care doctor is doing it so that they can get free CME, so they can keep their own patients, and other benefits of the professional satisfaction, but they are not actually being paid to do that. And the time commitment is 1 to 2 hours every week.
And they're not paying for it? They're not paying for it?
They're not paying for it.
Is the satisfaction, professional satisfaction being tracked in this that you know?
It is. It is being tracked in the ECHO model. And so Project ECHO in New Mexico has several states that have already signed up to start Project ECHO, and all the data from all the states is going into a big database. So ours would be joining that, and professional satisfaction and outcome, patient outcomes are all being tracked. Who's first?
Go ahead.
Go ahead.
I know that this really hasn't gotten started in Missouri yet, so maybe we don't know locally from this, but maybe in New Mexico. I can see from a patient perspective, if they live out in kind of a remote area, how it would be beneficial to not have to go to an urban center to get treated. But is there any concern from the patient's point of view that, like, in particular on the list I saw the high risk of B. Like, if I'm pregnant and I know I'm having a problem, I think I'd be a little concerned, like, should I really be going to just my primary care doctor, or shouldn't I be going to a specialist? Is there any?
Well, in the case of high-risk OB, it wouldn't be the primary care provider that would be being trained. It would be the OB. So whoever would be managing their OB care would be trained from the maternal fetal medicine specialist. Okay? So not a lot of places still have OBs, but so Rolla has OBs. They don't have any maternal fetal medicine doctors. So if those OBs there would be part of our Project ECHO to train them, then during the course of the pregnancy, if it's high risk, then they could be co-managed from here, but perhaps for the delivery, they would still come here.
Another big difference in New Mexico is that many of the reservations in Indian Health Service relies on nurse midwives. And so these are people they're familiar with seeing and can manage pregnancy better.
I mean, my question would kind of apply to all of them, but that was just one example I could think of that might be especially sensitive. Like, shouldn't I really be going to?
But those high-risk OB patients oftentimes won't come in because it's such a long distance.
And the same for hepatitis C. They can't afford to drive that far. They can't take off work or whatever the reason might be. And so getting treatment, it's not the difference between getting 90% treatment or 100% treatment. It's getting no treatment.
Right.
Okay, I think.
And would those patients in that case, would they know that their doctor is having this consult with the specialist?
You know, we talked to Dr. Aurora about that, and they don't have to know. So physicians have their scope of practice, and they can work within that scope of practice, and they can consult with other physicians on cases without the patient knowing. I would say that most of the primary care providers doing this are talking to their patients about that, but they don't have to know.
It seems like it might be a comfort.
Right. Yeah, and I don't think that they're having a consent form that's letting all of them know that. I don't think so.
I'm excited about this model. This is very innovative, and I like the approach. Instead of just telehealth to a patient, it's to those providers that are in that community and reaching out, and they know their community the best. And so I sit on kind of a lot of state partnerships, and this to me answers some of those hurdles, some of the barriers, and can break down a lot of those barriers. Do you do talks to other
We will be.
publishing groups?
Yes, we will be, and I'd love for you to help me make a list of who that might talk to. So, my email address is here, but it's probably also in some materials somewhere, so please feel free to let me know. Right. But one of the reasons that we got so much buy-in from the state is that it does help communities be so much more self-sufficient. And when you can take care of your people in your own community, and all those health dollars stay local as well. So all the pharmacy money, all the lab money, all the testing money, all of that dollar stays local as well. Yeah. That's right.
And the other thing that New Mexico uses a lot of, excuse me, are community health workers. And my public health background always says you really don't understand your patients till you see where they live.
Yeah.
And that is a very important part of a lot of what goes on in communities and why we say people are non-compliant. Well, they may be as compliant as they can be, but we don't know what they're dealing with at home. And so many of our folks suffer from the head bob syndrome. Do you understand?
Mm-hmm. Mm-hmm.
Where
Yeah.
they really don't.
That's right. So this model goes for, you can do physician training, nurse training, as well as community health worker training. So some of the echoes that...
You put in the pharmacist,
Mhm.
that's something that is really, at the state level, we're trying to do more of that connection,
Mhm.
Especially when it comes to heart disease and stroke.
Right.
prevention.
Great. Thank you. Yes.
So I know like rural physicians and even community workers often have a very broad scope of practice, but like based on the data so far, how often do physicians feel like the cases they take on are too complex for them and have to refer them?
Have you had physicians like drop out or end up referring?
So again, we haven't started it here yet, but from the University of New Mexico, what we found was that they're encouraged by the interdisciplinary group of specialists to keep patients, except for the very, very sick patients that they would want to go ahead, still refer. So in a way, Project ECHO works as a triage system. So you're treating more patients, but you're also still funneling the sickest patients to the specialist, which we talked about earlier, practicing to the highest level that you can. And so I don't know specifically about when those primary care doctors feel like they can or cannot manage the care of the patient, but they do. For hepatitis C, it's a pretty cookie cutter approach to treatment. You have to fall within very distinct guidelines in order to qualify for treatment. So if you qualify, then you can be managed by that group and co-managed by the subspecialty group. But as far as other of the specialties go, I don't know. I mean, I think that's something that we will be finding out. Yeah, good question.
I just, I know our counties are considered counties of need, and we're having a difficult time retaining physicians, nurse midwives, nurse practitioners in those counties, and I'm really looking forward to this. And if you've done some research and heard about telehealth, is there a focus on implementing the ECHO with those counties that are defined counties of need, or are you just
So we, again, it's sort of any willing provider, primary care provider that stands up and says, so we're going to be organizing talks around each of the disease states around the state, working with the AHECs to get primary care providers from each region to come to our talks and volunteer to be participant in an ECHO. We are focusing a lot on the federally qualified health centers. We've been asked to do that by some people at the state. So, but that doesn't limit us to working with the federally qualified health centers.
Okay, I think I'm getting the signal from the back here that we need to wind it up and have our snacks. So thank you all for joining us here today and a great conversation.
Thank you.